Hello, everybody, and welcome to our talk today on prescription drug abuse, the tip of the iceberg. Now, this is a very large topic, and we only have an hour, so we're going to be hitting the main points, but my hope is that you'll walk away with a much better understanding of the issue and the different ways that it is handled in daily practice. This is my information here. I'm board certified in family medicine and addiction medicine. Don't hesitate to reach out to me. And my contact information is there. Currently, I work in a chronic pain clinic part-time, doing group visits, which is an interesting model to deliver care to patients with chronic pain. I also have a small addiction treatment center that I'm the medical director for and work with another physician there. And then I spend the majority of my time building training programs, which I plan to make sure have a healthy component of education on the use of opioids and the treatment of addiction and chronic pain. Special thanks to Mary McMasters, who I used to present this with and hopefully will get to in the future. Quite a few of these slides come out of our joint presentation. These are our learning objectives for today, and so let's dive right into the epidemic that is addiction. Many people don't realize that the same number of people who have diabetes are struggling with substance abuse. It's very, very common. It's one of the main arguments behind my recommending that everybody have at least a working knowledge of addiction. I would say every medical student or pharmacy student or PA nurse practitioner student graduates their training with a basic understanding of diabetes, and that should be the same thing for addiction. Addiction drives quite a bit of the costs in our health system. As you can see there, 25% of emergency department visits are associated with inappropriate use of pharmaceuticals. Much of that is stimulants and opiates in particular. You can see overdose deaths have surpassed motor vehicle accidents, not just nationally, but also individually in most states. It was quite a few years ago that this happened in Virginia, which is where I live. It also increases people's morbidity, not just mortality, 13 times more likely to die. And the other thing, interesting statistic there in the last bullet, is that money spent on treatment is a good investment. And you get a 10 to 1 basically return on your investment when you talk about the cost to society with addiction. It's a shocking photo, but a reality that actually healthcare workers are at increased risk for substance abuse. And what does that mean? Well, that of course means that you are, if you are in the healthcare field, but it also means that we need to know what to watch for in our colleagues. Typically, there are signs that you see ahead of time. Here is how the physician was maintaining his blood level of his drug of choice. Most people, when they initially get into addiction, it's the euphoria that gets them. But once they are addicted, then it's the miserable process of really just trying to stay out of withdrawal. And that's likely what he was doing here, working while at the same time administering his drug of choice to himself. So what actually kills people, it's not so much that it's the actual drug itself. Obviously, it's the side effect of, in particular, respiratory depression. And often it's not just the use of one drug, but multiple drugs. Often alcohol and benzodiazepines, or opiates and benzodiazepines, or opiates and alcohol are three very common combinations that end up resulting in respiratory depression to the point where really people go into respiratory arrest, which leads to cardiac arrest and death. Costs are huge, and really one of the most striking statistics is there at the very bottom, that only 25% of people taking controlled substances are taking them the way that they are directed. Now, this can go both ways. Some people undertake their medicine, and some people take too much. And it's important that we spend adequate time educating patients about how to take their medicine, why it is that we need them to take the medicines that way that we prescribe them, and then to monitor them when they come in. Ask them how much is left in their bottle. If it's PRN and you gave them a 30-day supply and it's 30 days later and they've only used half of it, have a discussion around that. And if they really are only needing half of it, then when you refill it, just give them half. Having extra medicine around the house, as we'll see, is a significant risk factor for the loved ones in their life and the friends of their loved ones. So as I was saying, this is a busy slide, but it's actually quite straightforward. So here, let's say you have a patient comes in who they say that, yes, they have an addiction problem. So where are they getting their medicine? The majority, 54%, that's the blue, say that they are getting them from a friend or a relative. So over half of the patients who are using pain relievers for non-medical use got them from a friend. Well, where did the friend get them? Well, that's the smaller circle down to the right, the red. 80% of those individuals got them from one doctor. So the majority of patients are not doctor shopping, seeing doctor after doctor after doctor. They're getting them from one physician, and then somebody else is getting their hands on those medicines. And the important thing there is that, yes, your 65-year-old grandmother that you are giving Lortab 10s, 2 a day maybe, and she's not taking them, those medicines end up in her pill cabinet. And then her grandson comes in, gets them, gives them to a friend. That friend takes them and overdoses. So you don't give more medicine than a patient needs, and then you need to educate your patient that just putting them up in the cabinet is not a way to store them. They need to be locked and ideally kind of put away where people wouldn't necessarily look. So why do some prescribers prescribe unwisely? You have the patient who's getting 120 Lortab every single month and no efforts are made to check a drug screen or have them bring in their pill bottle or check the prescription monitoring program. Well, we group physicians into 4 groups, one is dated, meaning they just are not up to date. They don't understand the value of the prescription monitoring program or the urine drug screen, which should be being used ubiquitously today. They are duped. So that's usually that the physician, sometimes they don't think it's really their job to try and figure out, how the medicine is being used. They just take the patient's word for it, and they don't go in with a little bit of healthy questioning of why the patient is actually there. And if you know what signs to look for, and you do some of your due diligence with, like we said, urine drug screening and prescription monitoring program checking, you can avoid that. Disabled means the provider, may have a substance abuse issue themselves, or they're struggling with depression or anxiety, something that impairs their ability to practice wisely. And then there are a few out there who are dishonest. They are prescribing drugs and getting monetary kickbacks or other favors from patients, and they know exactly what they're doing. But they are by far the minority. So we talked about how addiction is a serious epidemic. Let's talk a little bit about what's going on inside the brain. So if you didn't see the martini glass, I'll put it out to you. But the point being that addiction is a disease. It's a brain disease of neurotransmitters in the brain reacting initially to the drug of abuse, and then a cascade gets set up such that stopping the addictive behavior isn't just a matter of the will. So when we talk about addiction, we always like to talk about terminology because there's some confusion out there with the terminology. Physical dependence, everybody understands that if you are dependent on a medication, when you stop it, you have withdrawal symptoms. And then as you go through those withdrawal symptoms and your blood levels come down to 0, your body detoxifies, and eventually the substance is completely out of your system and your withdrawal symptoms go away, although you can continue to have drug craving. Intoxication usually involves the nucleus accumbens and dopamine release, but is an altered mental state of typically involving euphoria and decreased mental alertness, decreased coordination, eventually decreased respirations, as we talked about, and in an extreme case, respiratory arrest. Substance misuse is using a drug other than what it is intended for, and this can take many different forms, but in our cases, it's usually taken either for the euphoria or to prevent withdrawal. Tolerance is the phenomenon where in order to get the same response from a drug, you have to take a higher dose. The longer you take a medicine, you start to build up that tolerance, and so it takes a higher dose to achieve the desired response. It's common in opioids as well as benzodiazepines and alcohol. You build up tolerance and you have to, for example, drink more in order to get intoxicated. And then lastly, addiction or substance abuse is compulsive use and continued use despite adverse consequences. When you stop it, you crave it. That's different than withdrawal symptoms. Craving is a higher brain phenomenon of you remembering the way the drug made you feel, and so you seek that, you crave that feeling. And then finally, you start to lose control of your use. The red area in the brain is a nucleus accumbens, and you can see different drugs act in different places. Heroin works back further in the brainstem and then up into the midbrain at the nucleus accumbens, which releases dopamine. The big red arrow up into the prefrontal cortex is the dopamine following along the synapse, and causes that in your conscious mind, that feeling of euphoria, as well as the memories of the way you felt when you took the cocaine or the heroin or even nicotine. There's also evidence to show that even high fructose corn syrup acts here, and even the process addictions, such as pornography addiction, have the same sort of release of dopamine. Now, we talked about how addiction is a brain disease, and the reality is that some brains are more susceptible than others. And this shows here that individual differences in response to drugs. So you give the exact same dose to an individual, to two different individuals. One has high DA receptors and the other has low DA receptors, and you can see the amount of stimulation in the brain is different. So subject A takes Lortab 10 and doesn't really feel that euphoria because they are a low DA receptor. Another subject, subject B, takes the same Lortab 10 and he's a high DA receptor and he has that sense of euphoria and it's a pleasant experience. And so the natural human reaction is to seek that pleasant experience. And they are more likely to end up becoming addicted. So we talked about how, drugs of abuse trigger the natural reward system. We talked about dopamine. And again, like we said, there are lots of other things that can trigger this system. There's food that's called hyperpalatable, meaning it's been engineered with the perfect combination of fat, salt, and sugar. And with the perfect combination, like you find in Cinnabons, it makes the food even more taste better than normal food should. And in studies with rats, that's the kind of food they will eat to the point of obesity. If you give them regular rat food, they won't. They'll just eat what they need. But hyperpalatable food, they will continue to eat and continue to eat to the point of death from obesity. These next couple slides show what's happening in the brain level in dopamine. The red spike are from drugs that either by their nature or by the way they are taken give you a very quick peak of dopamine and then it tapers off quickly. And that's the pathognomonic route to addiction, that spike in dopamine. And you can see over to the right, the green arc is those opioids that have a slower onset of action, a longer half-life, and thus are less likely to cause addiction. Typically, we find with addiction, it's not the very first dose that gets people addicted. So you can see these dopamine spikes. This person might be 18 when they take their first drink, and they get a spike of dopamine when they get intoxicated, but they aren't addicted. They continue to drink, and over time, these repeated dopamine spikes gradually get them up to what we call the inherited threshold for addiction. We find this is true in nicotine, and so in many different types of substances of abuse, there's this phenomenon. So unfortunately, this can be accelerated. So here, person is using frequently. So this is the difference between somebody who just drinks on the weekends and somebody who's drinking every day, for example. So they're going to get to that threshold point more quickly, and they'll be addicted at the age of 24 instead of 30, as we saw earlier. The other thing you can do is you can lower your threshold. Either it can be lowered because of the way God made you, and your addiction threshold is just lower. Those are your high DA receptors, people who are more sensitive to the euphoric effects of a drug. Or also, if you start earlier, so if you started when you were 13, that also decreases your threshold. This is another definition for addiction. I think the key thing to remember in treating patients with addiction, or even just working with your regular patients and wondering which of those might be addicted, which, again, remember, 10%. So 10% of the average population is struggling with addiction in some form or fashion. And so you know you have them in your practice. It's just a matter of finding them. Remember that it's their behavior is something that is bad for themselves and likely society, but they're not bad people. It's a disease. And when people make bad decisions with their diabetes and don't take care of themselves and let their blood sugars get high, we really shouldn't get angry with them. We should view it as an opportunity to educate them, come alongside them, help them understand what's going on and why it's happening, and see if we can't get them to consider seeking treatment. And also that they need help. So if a diabetic is out of control, they're likely not going to get in control without some help. This is a diagram of what's happening in a non-addicted brain versus addicted brain. And the key thing is that blue circle at the top, right? So in a non-addicted brain, our brain's ability to control what's going on inside of it and our behaviors is the dominant effect. And so that higher brain function overrules saliency, which saliency is a word to describe what gets our attention. And so, if you're a guy and you're sitting on a beach and a lady walks by and she is pretty, then our brains are wired to see that. If you're a mom and your baby cries, you may be distracted, but you're going to very immediately be able to shift your attention to that because it has very high saliency for you. Well, unfortunately, in patients who become addicted, the saliency for their drug of choice grows larger and larger and larger. And that's what you see on the right-hand side is the saliency gets to the point where it overwhelms the ability of the brain to control the drive or our behavior. And so you take an action doing something that the control part of your brain knows is not good for you, but the drive and the saliency overwhelms it. The memory reinforces this because the memory is selective for the positive aspects of the euphoria and the other aspects of drug abuse and the relief from withdrawal that you find when you use. Judgment clearly is impaired, and the pilots, what's salient for them is they're flying in the clouds and trying to fly the plane. They're not even thinking about the possibility of a mountain ahead, and so it doesn't occur to them that that's probably what they're about to run into. So we talked about addiction is a serious epidemic. It's a chronic brain disease. Let's talk about how easily it can be identified. And just a pause here. Docere is the root word for doctor. It's Latin. And in Latin, the word means teach. And so I just pause for a moment and ask you to reflect that if you're a healthcare worker, you by default are a teacher. You're teaching your patients every day. You're probably teaching your staff every day. And this is a natural part of being in the healthcare profession and is a great responsibility and a great privilege. So we talk about universal precautions in pain management and why are they necessary? The most important reason they are important is because you can't really tell which patients have an addiction problem and which ones do not. That's where universal precautions first came about in infectious disease, is because you can't tell who has hepatitis or another communicable disease, and so we treat everybody as if they do, wear gloves and that sort of thing when we risk exposure. Same sort of thing with addiction. There are certain things we should always do to help protect the patient and ourselves from the medicines that we use. So first step, of course, make a good diagnosis with an appropriate differential. You want to assess the psychological aspects of the patient's risk, both family and personal history. And not that these are contraindications, although personal history is going to be probably almost an absolute contraindication to using these drugs unless there's just no way around it. But just to be aware and educate the patient that if they have a family history of alcoholism, that writing them a benzodiazepine for 2 weeks during an acute grief reaction is more risky for them than for somebody who doesn't have a family history of alcoholism, for example. Personal substance use, the safest level of use is 0, and there's no way around that. If somebody asks you, that just is the fact. Not that you can't use responsibly, but everybody needs to understand. And if they have other risk factors, it may be better for them just to stay away. We break different risk factors into biological, psychiatric, and social. So when you talk to your patient and you interview them, if you make sure to ask these questions, in particular around psychiatric history of sexual abuse is a key one that has a significant impact on the likelihood of substance misuse in women in particular. If you ask the right questions, you'll have a much better idea of how much at risk your patient is. You can see the physical signs. These are track marks. These are track marks being attempted to be hidden by a tattoo. This is an abscess from injecting, and these will often present to the emergency room, and patients will say they got a quote-unquote spider bite. Let's look for other track marks and query the patient and probably get a urine drug screen. These are skin marks from skin popping, which is where if an addict can't find a vein, then they will inject their drug of choice subcutaneously, and for it to be absorbed that way into the bloodstream doesn't give as much of a high, but it still will help them in their withdrawal symptoms. Often these signs are pretty easily seen. Patients sometimes come in with sweatshirts on and just ask them to remove them for a thorough exam so you can see their arms. Make sure to get informed consent before you write a controlled substance. And also a treatment agreement. And these two really can be one as a general rule. When they sign the treatment agreement, in there is the information, the education around the risk of the use of the medication. Your treatment agreement also talks about the rules for your clinic, how you're going to be monitoring them, and help them understand why you're getting a urine sample, for example. You want to measure function, and that can be more casual in terms of are they working, are they not working, what hobbies are they doing, and then you want to, or it could be formal testing, and then you want to follow that over time and monitor, and you should see increasing activity. They should get back to work. They should be taking part in hobbies, taking care of grandchildren now, that sort of thing. And then you make a conscious decision, are they appropriate for opioid therapy or not? And the plus minus adjunctive medication is important because opioids are just one substance that we can use to treat chronic pain. And there are lots of different adjunctive medications that can be used to help decrease the amount of opioids that a patient needs. And in fact, I've seen patients be able to come off of opioid therapy with the right combination of adjunctive medications. And there are other also non-pharmacologic treatments for chronic pain that you should consider. You want to reassess the pain score and level of function when they come in for follow-up visits, and also regularly assess the 5 A's of pain medicine. So how is it working in its areas of analgesia? What's their level of activity? Are they having any adverse effects? Are you seeing any aberrant behavior, early refills? They come in intoxicated, that sort of behavior, or asking for very specific drugs or allergies that make no sense pharmacologically or biologically. And then what's the patient's affect? That's getting at, are they hyper? Are they are they impaired? And then periodically you need to step back and review your diagnosis. Sometimes patients come in and they don't have a herniated disc, for example. That doesn't mean they can't herniate a disc. Over the years, these patients are typically chronic patients over time, and their chronic back and shoulder pain can actually go from being more musculoskeletal to cardiac condition, for example. So this is a summary slide. And again, make sure you're documenting your thought process as well as your treatment. So lastly, addiction is treatable. And the key thing about treating addiction is just plain detox doesn't work. You also need to treat them with other modalities other than just getting them off their drug of choice, and ideally treat them over a longer period of time with other medications. That doesn't mean that they all need medication-assisted therapy, but typically these patients will need a treatment often for other comorbid conditions such as anxiety and depression. Certainly counseling is key, as we see here, and we like to use a combination of both individual and group. Those two different counseling methodologies provide different benefits to the patient, and so we use both, and we vary the frequency of them based off of how well the patient is doing. If they're not doing that well, they need more support, then they get more counseling. Support groups are self-explanatory: AA, NA, Celebrate Recovery. They are, as a general rule, free and very effective. And while a lot of times patients initially don't like going to them, again, the data would suggest that they are very effective. And then lastly, adjunct medications that can include clonidine for those if they want to not be on medication-assisted therapy, or they can't be, then you can, because they're on probation and their officer won't allow them to be on a medication to assist, then you can try clonidine, for example, is used. And then also the other medicines for psychiatric comorbid conditions, as well as just treating any other medical problems that could impact the patient's health. This is a nice slide that shows, the different levels of care, both for diabetes on the left as well as addiction on the right. And the vast majority of patients with diabetes can control their blood sugars just with basic teaching, home monitoring, what they eat, that sort of thing. Same thing with addiction, especially if we can catch it early. Then you can counsel them, get them into counseling, get them into a 12-step program like AA, NA, Celebrate Recovery. And quite a few of those individuals can get sober and stop their cycle of addiction without the use of medication-assisted therapy. But for those who need it, they need it. And then the very top few end up needing to go inpatient to stabilize them, and then an outpatient program. Remember that often the patients do have psychiatric diagnoses, but you can't really tell that until you've had them out of their cycle of medication abuse for about 6 months. A lot of them will go away when the brain isn't being subjected to those recurrent dopamine spikes. So the use of your drug screens should be much more common, and I tell patients it's like checking blood sugars and A1Cs and cholesterol levels and that sort of thing in patients with other medical conditions. It should be part of your usual armamentarium. This is a very important slide. The prescription monitoring program in Virginia now has on the front page their morphine equivalent daily dose. And so it converts whatever drug the patient is on, whether it's Dilaudid, hydromorphone or hydrocodone or oxycodone, and converts it into morphine equivalent dosing. So it tells you the level of opioids regardless of the type of opioid. And basically, 80% of the bottom two groups of patients account for 80% of the overdose deaths. And of those overdose deaths, let's say there are 100 in Virginia every year, which there are more than that, but let's say there are 100, 80 of them come from these two bottom groups. Of those 80, 40 of them, and all of them have a morphine equivalent daily dose greater than 100. So if your patient is on greater than 100 morphine equivalent daily dose based off of the P&P that you get, they are at a significantly higher risk for overdose. So half of those overdose deaths are from a single prescriber. And I would argue probably most of you listening to this presentation, the patients that you are treating who have a morphine equivalent dose greater than 100, that's probably you, because you think you're the only prescriber, and you may well be. If you're checking the P&P, you'll know. And then 40% of them are getting the meds from multiple prescribers, and unfortunately those prescribers probably are not checking the prescription monitoring program. Our P&P can check our adjoining states now, and so there really is very little excuse for providers not to check it and to understand where the patient's getting medicines from. So the biggest take-home point for this is the value of the prescription monitoring program. It literally takes 30 seconds to a minute to punch the patient's information into the website and to get the report back, and the information is very helpful. Here's just a sample, and this is an old copy. And if you have any questions on reading the prescription monitoring program, just call Richmond and talk to the program. They're very helpful in explaining. This one is the list of providers, and you can see 23 different prescribers for one patient. And evidently none of them were checking the P&P to see the other 22. So in treating, we talk about different domains of care. And I like to use this rubric for trying to decide which patients can I treat, which patients can the primary care provider treat, and which patients do I need to refer, because I'm kind of in the middle I do have some specialized training, so I'll take care of patients who are at higher risk than what I think a primary care provider ought to tackle. But there are patients that I need to refer. So settings of care, there's all the way from primary care up to specialist care. And you look at the pain etiology. Is it clear what's causing their pain, or is it not clear? Do they have a lot of psychiatric disorders? When you're looking at treating pain, do they have a history of substance abuse? What's their social support like, and how active are they? And so if they have a lot of psychiatric illnesses or a history of substance abuse within the last 3 years, or they don't have any social support system, then those patients are at significantly higher risk and you should consider referring them. But if they're not, then you can treat them in your clinic. Selection of treatment. So you want to select treatment that has the best benefit with the least risk. So always remember your non-pharmacologic options. You want to make sure you're addressing medical comorbidities. How are they sleeping? Do they have a roof over their head and reasonable food, access to reasonable food? And are they deconditioned? Would they benefit from some physical therapy, or even going to the local YMCA or other rec center for some training on how to get themselves in a little bit better condition? Take into consideration the patient's preferences, and then different cognitive abilities allow for different treatment modalities. And then lastly, your skills. If you know how to do acupuncture, then that could potentially be something you could offer the patients. Supply of medicine, we talk about the bottomless bottle. So it's the difference between giving somebody 30 Lortab 10 versus 60 Lortab 5. Now, when you look at the bottle, if there's 60 tablets in there, it looks like you can just take as many as you want each day, and you're never going to run out. And it's the total amount of narcotic in that bottle is the same, but ideally you want to give them fewer tablets, and it makes it less likely that they're going to eyeball the bottle, especially if it's a PRN dose, and think they can just take 4 or 5 today and each day and not run out. Lastly, scheduled versus PRN. As a general rule, most of the patient's pain medicine ought to be on a scheduled basis if they have chronic pain every day. And then whether you include what we call breakthrough medicine for the patient depends on the patient's situation and how trustworthy they are, and the nature of their pain. You can sometimes enlist family to help with dispensing. They keep the medicine, they keep it locked up, especially if the patient has a mental impairment, whether it's dementia or a brain injury in the past, that they just forget whether they've taken it or not. So better just to put it in the hands of somebody else that you trust, and they can dose it to the patient. Supports for recovery. Do they have access to recovery groups? Can they get a sponsor? What's their faith community? Do they have a supportive family? Can you get the family into therapy? Because certainly this is a disease that affects those who are around the individual. And if they're working, what's their workplace? Is it supportive? Is it not? I mean, just remember, if the patient is working full time, that's 8 to 9 hours of their life that's spent in an environment that is either going to be supportive, ambivalent, or not supportive to the recovery. Ideally, it would be supportive. Supervision of care. So how often do we see these patients? In primary care, a lot of times we're into a mentality of, I see the patients every 2 to 3 months. Well, that works for a lot of medical conditions, but for something like this, and this can be just getting your patients to stop smoking, you may need to see them every week, or every 2 weeks, and maybe it's really a nurse visit and you pop your head in just to say hi and to cheer them on and address any issues that have come up. But especially at the beginning of therapy, frequent visits can be very helpful to the patient. We already talked about checking urine drug screens and prescription monitoring programs, and let me just put a plug in here for saliva drug screens. The value of saliva drug screens are that they are direct observed, and you know exactly what the patient is You know exactly the sample that you've gotten. And not that you would use those all the time, but using them randomly, as well as for anybody who you are concerned might not be giving you a legitimate urine drug screen and you don't do direct urine drug screens. They are very handy to have. They have point of care types of saliva drug screens, and they are coming more and more into use. Don't forget about your ancillary providers who can help you out in the different settings of care. And this is, it can be a challenge in really rural areas, but don't forget your clinical pharmacists, your interventionalists, that sort of thing. So, above all, don't forget that 10% of your patients are struggling with substance abuse or addiction in some form or fashion. It's very common. You should ask about it. And when somebody indicates that they have a problem, remember that it's treatable. Tell them that. And then if, depending on your situation, you may have some things to offer them. You may not. You may need to refer them. Certainly, you can always offer them Alcoholics Anonymous and other support groups that are already up and running in the community. And I highly encourage you to have a plan of where you will refer that person for treatment once you identify them, other than just AA. Thank you again for spending time with me today to talk about addiction. Again, my contact information is at the beginning of the slide deck, and I really encourage you to reach out. I enjoy dialoguing with individuals across the country about this epidemic that is sweeping the United States, and it's no community is immune, and it is a significant problem, to include obesity. We didn't talk much about that other than the hyperpalatable foods. But as we move into the future, I think we're going to continue to see a growing problem with addiction in America. And hopefully now you have some new tools that you can use going forward. And would love to hear some success stories from you as well. These are our references. I'll scroll through them briefly. And I hope everybody has an excellent day. Thank you for listening. Goodbye.